So the plan for today is we're going to do part 1 and part 2. We'll get through like just the basic overview of the GI system. We're going to look at just specifically the oral cavity. And from then on, we're going to follow the path of food from the mouth, then we'll do the esophagus, stomach. So the functions of the GI system is such that obviously ingestion, we're going to be bringing food in. Mechanical processing. Mechanical processing means we are going to be chewing, teeth crunching our food. That's just, so think of like a Ritz cracker. You lay it on the table and you hit it with a hammer and it just breaks up into lots of little pieces. That's mechanical breakdown, a mechanical digestion. We're also going to be doing chemical digestion. That's where we put chemicals and mix it with it, and the chemicals will actually break bonds. So it'll take our proteins, break the proteins down into individual amino acids. So mechanical just means putting things into smaller pieces, but not altering its chemical structure. Chemical digestion, which we're going to work on in 2 more lectures, we'll go over what are the enzymes or other chemicals we use to actually physically break bonds. Secretion throughout our GI tract means we're going to secrete like acids or buffers, things like that throughout the GI tract. Even mucus for lubrication for food. Absorption, once we break things down sufficiently, then we want to then absorb it. So we want to think of our GI tract from mouth, it goes from mouth to anus, as outside. Think of anywhere a penny goes. If you swallow a penny, it goes in your mouth, goes down your esophagus, and all along we're going to have epithelial tissue that's protecting us from outside to inside. That penny drops into our stomach. We then send it on into the intestines, zips along the intestines. It doesn't get absorbed at any point, so it doesn't get inside or absorbed to actually circulate through our blood and in our bloodstream. So that's part of the absorption, is selectively defining what crosses over and gets into our bloodstream and then therefore in our body. And what doesn't make the cut and crosses across that epithelial tissue then just gets excreted out and out the other end. So the general features we're going to talk about, the peritoneum is a serous membrane, part of the serous membrane that goes around the guts. We have a greater omentum and lesser omentum. So this image is one of our cadavers here, where you can see the musculature of the abdominal cavity has been open and pulled aside. And then we can see that there is just a thin membrane. So if you open up the muscle, open up the gut, that you think you're going to see guts? No, you're not. You're just going to see this membrane. So we have a hole in it, and then you can lift it up. So you can see that is the parietal peritoneum. And then when you cut it from the side, you can sort of lift it up and see how thin it really is. But what you can see here is this is the stomach. There's the liver. This is part of the lesser omentum here, stomach. And then we have greater omentum. It sort of hangs from the greater curvature of the stomach, a lot like a shower curtain. You know, it's not attached the whole way. It's just got points of attachment across the bottom of the stomach. The mesentery is really where we have our visceral peritoneum. That's touching the surface of the intestines, coming to the back wall before it then becomes going around as the parietal peritoneum. So the mesentery is this connection coming back. You can see a side view of where we would have visceral peritoneum on the surface of each of the intestines. If we have just a straight cross-sectional cut here, mesentery is where you're getting that peritoneum membrane coming back, and they're all attached. And then we go here to parietal, which is going to be this outer layer. The layers of the GI tract are going to be 4 main layers, and this is going to get redundant. This is going to get redundant, and hopefully in a good way, because one of the more difficult things students struggle with when we do GI anatomy is the histology component. So we're going to look at microscope slides of the esophagus, of the stomach, of all 3 sections of our small intestine, of our large intestine, and a couple other things. But all those that I just named, you're going to be looking for these 4 layers. So again, it's going to get redundant because we're going to be talking about them for each one. The mucosa is the innermost layer that has epithelial tissue and some muscular tissue. That's going to vary from section to section. And when I say section, I mean a region, like the esophageal region, to the stomach. It's going to have different epithelial tissue in the stomach compared to the esophagus because it has different functions. We get to the intestines. We're more about absorbing some food and the broken down the digested nutrients. And so that we're gonna have different types of epithelial tissue there. So the mucosa is gonna vary as we go from each region or segment of the GI tract of this tube. And we wanna think of our GI tract as a long tube. It's one long hose. We have the esophagus section, the stomach section, the small intestine section, and the large intestine section. It's all one hose except for one area, being the stomach, is more of a pouch, and that one's gonna have a few alterations because of that. The submucosa is just under the mucosa. It kind of is like a no man's land to me. In this picture, it's the purple area with glands in it, usually large blood vessels. It's a lot of connective tissue, and this is where some of the glands are located. Then we have muscularis externa. It is the outer 2 layers of muscle. We do have an inner layer of muscle here, this pink layer below mucosal band. It's also part of the mucosa. So there's a tiny muscle layer there, but the muscularis externa are specific to these outer 2 layers. So we have the circular muscle, which goes around the tube. And so again, if it's gonna constrict, it's gonna squish down into the tube where food is here in the middle. Or we have longitudinal muscle. And these look like weird little circles. But what they are is also the same as the circular muscle, it's just from a different perspective. For instance, I grew up in Central Oregon. It's logging country. So it's cowboy country and logging country. So you're driving along, you're always seeing log trucks going down the road. And so when you see a log truck, if you're driving next to one, that's like the circular muscle. You're seeing the long logs. But sometimes if you're right behind the log truck, you're seeing the stump cut side, and that would be this version. So the cells, the smooth muscle cells here are coming out the screen at you, where these smooth muscle cells are going side to side and around. So when we eventually talk about peristalsis, which is moving food along, we do the whole squish, like we constrict down to pinch off, and then we do a scrunch. So squish, scrunch. That's how we're sort of shuffling food along. We have the serosa, which is just connective tissue on the way outside that's going to connect it to either the peritoneum or other connective tissue, or just kind of hold it in place. A lot of times when we look at the histology, we're not going to see the serosa at all. In this image, we can see in the red circle is the esophagus. It's usually collapsed down. This white inner area is where food would go. We can see the dark purple squiggly line and then a little lighter purple layer. That distance, that is actually stratified squamous epithelial tissue. Just like our skin, it's just not keratinized, where it doesn't have that one dark layer in the middle. So this is stratified squamous epithelial tissue that is just the same as what's inside our cheeks. And then it lines, goes down our esophagus. So it's meant to protect us from abrasion. Think about eating a whole lot of like tortilla chips. And you're maybe chewing them up or not chewing them as much in the smaller pieces as you like and scraping down. We have a nice thick stratified squamous layer that's as that's moving down. It does need to absorption, so it's nice and thick. We're not absorbing anything, we're not really secreting much, we're just protecting ourselves as just a tube bringing food down to the stomach. The trachea, in contrast, has a big wide open opening, thank you to the hyaline cartilage helping keeping that propped open. So I like this image because it shows both of them together. This image, we can see an example of an intestine. This lighter shade one is just expanded beyond its pixels capabilities are, so it's pretty fuzzy. But I want you to see that we have mucosa layer that actually includes these villi, sort of these are not the villi are these little tiny spikes off to the side. These are the folds within the small intestine. But this whole area right here would be our mucosa, just like this area is our mucosa. And then we have just submucosa that's just in the in-betweens. And then we have muscularis externa. We have our circular muscle and longitudinal. But look here, we're looking, so you can see that the angles or the direction of the fibers are going to be different. Not always are things sliced like you would ideally expect them. They get sliced at weird angles. So you will always know that the outermost layer is always going to be longitudinal, no matter which direction it looks like it's going. And just in from that will always be circular. They're always going to be in that pattern, that layer. This is again the esophagus, but back to the 4 layers. We've got our mucosa, which includes this little muscularis mucosa that's in patches. Submucosa is just a sort of whitish area, and that's really how it usually looks like. I always like to call it no man's land. You kind of don't always see stuff in it. That's just a submucosa, and then you have very distinct muscularis externa, where we would have our circular muscle and our longitudinal muscle. So just a recap on this, the mucosa is going to be our innermost layer. It is the layer that's actually going to be touching the food. We can absorb at that layer if we're in the intestines, or we can secrete stuff out that layer. It would be simple columnar epithelial cells if we're in the intestines, but if it's the esophagus, it's going to be stratified squamous epithelial tissue. Submucosa is just under that. This is where we're going to see blood, lymphatic vessels, and a whole lot of connective tissue. So it really doesn't have any prominent features outside of that. The muscularis externa, the longitudinal, is always going to be the outermost. Then circular is going to be just one layer in from that. And remember when I talked about our GI tract really being a tube from mouth to anus. One portion of it is a pouch, which is our stomach. The pouch is the only place I bring up here because it's the only place along that tube that we have an extra layer because of the three-dimensional pouch-like nature of the stomach. And that layer is known as the oblique. And it will be just inside of the circular layer. So the entire distance and duration of our GI tract, we will always have longitudinal, continuous on the outer layers. Then we have circular just in from that. And then only in the stomach, just in from the circular, will be this oblique layer going at an angle of those two. So we have, you know, longitudinal one way, circular is going to be exactly perpendicular, and oblique is going to be at an angle to those. Here's a nice image showing you perfectly like the log truck style. We can see the circular muscle that goes this side to side. It's going to constrict down when it contracts. And then we have the longitudinal, which is coming out the screen at you. So that's going to do the scrunch with the food in as far as the tube goes. And that's with peristalsis. We have the circular that's actually going to constrict there, and it pushes the bolus of food forward. And then we have the longitudinal kind of pulling the tube back. That helps move this bolus of food even more forward. The neural mechanisms, all this is just how do we regulate? There's so much going on. It's just giving you kind of a big picture. Autonomic nervous system, that's helping us through the parasympathetic side of branch of our autonomic nervous system, is enhancing digestion. So we've got, you know, increasing secretions. We have through the glossopharyngeal and the vagus nerve, we have muscles in our pharynx that actually begin the process of bringing food down. We have a point of no return. I think I have a slide coming up, but there's a point of no return for some food. If you guys say are chewing gum or have some sort of hard candy like a Lifesaver in your mouth, and you're standing there and one of your friends comes up behind you and whops you on the back and says, you know, hey, how are you doing? All of a sudden your Lifesaver goes to the back of your throat. There's a point where you start to swallow it, and then you don't really want to, and you're like trying to get it back up because you know it's probably bigger than it needs to be before it goes down. But that's because there's a point in your mouth that the smooth muscle will actually start to constrict and then bring it down through peristaltic contraction. So that's part of the autonomic nervous system. You don't really have control over that portion. The hormonal mechanisms we're going to talk about in a couple of lectures when we do digestion. That's really about one area signaling to another. For instance, the stomach, when it gets a whole lot of protein in it, is going to send a hormonal message to the small intestine to say, you better get ready, send some bicarbonate out because we're going to send a big acidic mass to your way. So get ready for some bicarbonate to buffer this. Or the small intestine may send a hormonal signal back to the stomach saying, hey, slow down. We have too much stuff we're processing here. Stomach, slow down, don't send the stuff so quickly. So there's some regional communication done hormonally that's beyond what we did when we did the endocrine system. And then there's local chemicals. Acidity is going to stimulate the release of bicarbonate and so on. So there's just a lot of varying layers or mechanisms of control. So it's kind of, I just wanted to be aware of that because we'll be talking about different ones as we go along. So starting here in the mouth, first place that we're obviously going to put food in, we have teeth. Teeth are meant for mechanical digestion, breaking up our food, putting it in smaller pieces. The mouth is defined by the superior border, like we did with the respiratory system. We have the hard palate, maxilla, palatine bone, soft palate behind that. Then we have the inferior border is going to be the tongue. What connects the tongue down is it's attached down to the lower mandible, as well as if you were to curl your tongue up, you can see a tether underneath your tongue. That's known as the lingual frenulum. On our tongue, the bumps that are on the surface of the tongue, if you stick your tongue out and have a look at it, people assume that is a taste buds, but those are not. Those are papilla, which means those are bumps. Taste buds really are taste cells, and the cells are down in the cracks between the papilla. So this is quite a nice picture where you can see one central papilla and you can see many of those taste receptor cells on the side. Okay, as far as teeth goes, you're going to need to know the regions of the teeth of a tooth. You are going to need to know the structure of a tooth, as well as the number of teeth and the types of teeth. So a tooth is basically the crown, which is what we're seeing on top of the gums. We have the neck as it tapers in, and then the root, which is actually what's going into the bony structure of either our maxilla or our mandible. So the structure of a tooth is we have this outer barrier layer. So this portion here, I'm just kind of coloring in hideously, that's going to be our enamel. It's a clear, hard outer shell. From our enamel goes down the cementum, which is down on the lining, the roots of our teeth, where our periodontal ligaments extend off of that. And that's what's then attaching to the bone directly. Then just in from the enamel, we have the dentin. That's the fibrous looking component in this picture. The dentin is the white part of our teeth. So the enamel is the clear part, the dentin is the white part. And that part is softer. So bacteria, if it's able to penetrate the enamel, will get into the dentin. And once it gets in the dentin, it's soft like cheese, and the bacteria will just burrow straight through. And then you have an opening into this pulp cavity. And that's when someone notices that they have a cavity. Okay, so as far as the structure of teeth go, you should know the three regions, crown, neck, root, and the basic anatomy. You've got your enamel, dentin, your pulp cavity. Cementum is on the side along the roots, and then it goes to the periodontal ligaments. The types of teeth we have are incisors. There are front ones, are Bugs Bunny teeth. They are for cutting, eating carrots. If you want to just pierce them like that, you think of horses and cows snipping off grasses. So it's meant to just snip things off. The canines or cuspids, those are only in animals that eat meat. And so we're omnivores, but carnivores have them. Obviously dogs and cats with a larger degree of very prominent canines. They are meant for grabbing onto meat so that you can then manipulate it and tear. So they're really not about crunching or slicing, they're about holding. So holding and tearing is the job of the canines. Bicuspids, premolars, as well as the molars are meant for crushing and grinding. The incisors are here at the front, canines here, as well as the bicuspids, premolars. You can see they're quite a bit smaller than the molars behind. Skull picture of a child. This particular child has already lost its bottom two baby teeth, and so these are the permanent teeth coming up in there. They have yet to lose their top front two teeth, because you can still see the larger permanent teeth up in behind. As far as salivary glands go, we have three main salivary glands you need to be aware of. The parotids are going to be here off of the mandibular ramus near the masseter muscle. Then we have the sublingual, which is under the tongue. And then we have the submandibular, which is going to be obviously under the mandible itself. So the composition of saliva, it's mostly water. It's obviously intended to help dissolve our food. Think about that Ritz cracker. We really want to dissolve it. We want it to make it where it's lubricated a little bit more so we can swallow it more easily. Salivary amylase. The amylase is an enzyme. Salivary amylase is going to break down carbohydrates. So we're not doing anything for proteins outside of just breaking up the food into smaller pieces. In this point, we are breaking also up the carbohydrates into smaller pieces, like the Ritz cracker and the hammer, or the Ritz cracker meat teeth, you know, just sort of breaking it up into small pieces. And then the salivary amylase starts our chemical digestion process. So we're actually beginning the process of breaking some of these down into smaller and smaller pieces, ultimately getting to glucose, which is why some of the carbohydrates that we eat start to taste sweet in our mouth, especially if you chew it for a really long time. We also have mucins, which are meant to add into the water to help lubricate food so we can swallow it and move it along. And we also have bicarbonate, and it's intended to neutralize acid. Here's some pictures of the 3 different salivary glands. This is their histology images. On the exams, I tend to use more of the submandibular one because it has a combined component of both the dark and the light acini. The acini are these circular little cell clusters. See, the parotids are a lot of dark acini, where the sublinguals is a lot more of the light acini. From our mouth, food next is going to head to our esophagus, and it's the tube that's going to bring us down into the stomach. We go from the pharynx, food's going down from the back of our mouth, down the pharynx, we have, and then onto the esophagus. In this image, we can see the trachea, where the air goes, and we can see where the trachea divides here in the right and left primary bronchus and the aortic arch here. On the posterior side of the trachea, we can see is the esophagus coming down. At this point, we can see where the diaphragm is. The diaphragm separates the thoracic cavity from the abdominal cavity, but the esophagus has to go through that diaphragm so it can bring food into the stomach. The whole diaphragm here that's known as the esophageal hiatus. Some people get higher pressures in their abdominal cavity, and their esophageal hiatus might be on the bigger side, and so their stomach, portions of their stomach starts to rise up and come through that. That's known as a hiatal hernia. Also in the esophagus, we have a sphincter high up, a little bit higher than that, and then a sphincter low. Pharyngoesophageal sphincter, which is high up, and the gastroesophageal sphincter, which is going to be low. Deglutition means swallowing. So we have the voluntary, meaning we're chewing food around, we're moving food throughout our mouth. And then the involuntary part is where there's a point of no return for the food in your mouth. Once it goes back a certain point, you have the musculature that's going to start contracting and squeezing and bringing food down. And that's going to start in the oral pharynx. When you eat food, you don't want food to go into your larynx. We have the epiglottis lifted upward. Our larynx, when we go to swallow, is going to rise, and what happens, our epiglottis that is up tips back so that the food that comes in the mouth is directed posteriorly to the esophagus. Once it's in there, peristaltic contractions are going to help move it along. This is what the lower sphincter looks like, the gastroesophageal sphincter. This is known as an incompetent lower sphincter in that it's not closed at all, you can see, and actually you can see some of the stomach rugae on the other side of that. So gastroesophageal reflux disease, also known as GERD, is where you have an incompetent lower sphincter, and you have the acidity that's developed in your stomach comes upward into your esophagus. And our esophagus is incapable of handling the acidity. Our small intestine, the first part of our small intestine, it's expecting stuff from the stomach. It's used to getting the acidic components from the stomach. So it has buffering components in the small intestine that we'll learn about at our next lecture. But the esophagus doesn't. So when it gets stomach content stuff, it's going to actually cause damage and burn. And under a chronic situation, that can be very, very painful and cause a lot of damage. In the mucosa, it's going to be stratified squamous epithelial tissue. And so it's just meant to be stacked up cells to resist abrasion. We have various glands throughout it, and obviously we're sticking with the same 2 muscularis externa for peristalsis. We can see in here how the esophagus is normally scrunched down. So this is where food would be, and the inside of this purple where the white is. So food really has to be pushed through. Then we have the dark purple represents a stratified squamous epithelial tissue. We can see these purple dots around here. That's actually muscularis mucosa. That's a nice landmark of where the end of the mucosa layer is. And then beyond that would be submucosa. It's kind of stringy connective tissue. And then beyond that is going to be our 2 layers that make up our muscularis externa. In the stomach, it's the most extensible. So it could stretch out, stores food, churns food, got the gastric juices that we're mixing up with it. But what do we want the gastric juices for? Is we are digesting proteins. Digesting in the chemical sense to break up protein bonds. When we're done churning and mixing and breaking down the protein, the food that leaves the stomach is known as chyme. Chyme is sort of this acidic, juicy food. The other important part of the stomach is the intrinsic factor. Intrinsic factor secreted by the stomach is used to bind to vitamin B12 when you eat meat. It binds to vitamin B12, then it makes its way to the small intestine. At the end of the small intestine in the ileum, our body will absorb vitamin B12 as long as it's hooked up with intrinsic factor. If you don't have enough intrinsic factor, you can eat a boatload of vitamin B12 and not absorb any of it. So we need the intrinsic factor to be linked with it for our ileum to absorb vitamin B12. If you don't have enough vitamin B12 that you've absorbed, either you don't eat enough or you don't have enough intrinsic factor, what problem would you have? Anemia, which one? Pernicious, the sneaky one. Because the sneaky anemia is you have the normal amount of red blood cells, you're making them just fine, nothing's destroying them, but your red blood cells don't have enough B12, so you're not making enough hemoglobin to be able to bind oxygen. This is a picture of the stomach. I want to point out this dark part is not a necrotic tissue. In a cadaver, this is perfectly normal. Because what's normally laying here, this is the liver is retracted so you can see it more easily. Normally this lays down. This is the gallbladder. The gallbladder we know is where the waste of the liver goes, and so it has a lot of bilirubin from the breakdown of red blood cells. So it's highly pigmented material. And when a cadaver has got formaldehyde going through it, the formaldehyde acts like kind of like a paint thinner, where it's actually allowing for this pigment to leach out of the gallbladder, and therefore in all cadavers you have a stained area. So it has nothing to do with necrotic tissue or anything bad or unique. It's actually quite normal for a cadaver because it's just pigment coming from the gallbladder. Having said that, now let's have a look here. We can see up high up there is where the gastroesophageal sphincter would be. And then down here in this area is where our pyloric sphincter will be. The pyloric sphincter is what's going to monitor the exiting of chyme out of the stomach. So if you draw a line here, I'm just going to put an F here, that means the fundus. That's sort of the hump portion of the stomach. And then we have what's known as the body in this main region. And then this last sort of triangular funnel region is your pyloric region. And then obviously it terminates here into the pyloric sphincter. And then beyond that is going to be the small intestine. So you can see these a little nicer in this drawing. Again, I want to point out the oblique layer. This is the only place that we're going to have this extra muscle layer as an oblique layer. So the longitudinal is going to be the most superficial of these 3 muscle layers. It's going to be adjacent to the circular, which will then be adjacent to the oblique in the stomach. This is what a stomach would look like with rugae. This pic been cut down the esophagus and through the stomach and then just laid open. So you can see the rugae, and the rugae are the folds on the inside of the stomach. So this is a very normal, healthy looking stomach. The rugae allow for a huge amount of expansion. The gastroesophageal sphincter about here. This is the pyloric sphincter. So this is the first part of the small intestine. This is the pyloric region of the stomach. This pyloric sphincter is like a little donut circling this area that's just been sliced. So you can actually see two. This is a picture of a healthy stomach. It just has a penny in it for reference as far as seeing the size of the rugae. This is the pyloric sphincter. Again, it's like a donut. This is the perspective if you're in the small intestine. The inner mucosa of the stomach, when we talk about gastric pits, picture it with the rugae all ironed out, nice and flat. Think of it as this flat surface, and the gastric pits, if you want to think of this as sort of this flat surface here, gastric pits are like gopher holes going down into this. So you have the gopher holes going straight down into the mucosal and into the wall of the stomach. Are you guys with me as far as that perspective goes? I'm pointing this out because the next image is kind of wrong in this part. So I want you to have this image in your head that what we're going to do when we look at what's in a single gastric pit is picture it as a single little hole going down into the wall, you know, going down to the, if this purple here is actually the mucosal layer. Then if we have rugae mushed together, obviously there would be like little gopher holes on the side, up and over the hill, little gopher holes coming down, and you know, that way. So I wanted you to see that the next picture is wrong. I'll show it to you. The only part that it's wrong is up here, where it's showing the gastric pits coming down are not between the rugae. A gastric pit is just smaller than that. It's actually a little gopher hole into the wall here. It's this, the artist of this, I like the rest of it, and I need to change this, but the rest of it's good if you don't see the rugae on the top part. So essentially, if you imagine a flat field, that would be a stomach lining with gopher holes in it. Then all of a sudden you have rolling hills. You would have gopher holes going up the hill and down the other side. And what we're going to look at in this histology image is just a section of this patch of land that may have 10 or 12 gopher holes, right? The way they drew this here would be like a rolling hill and a rolling hill together. So they've got the perspective all off. Question is, I like you to see that there are these pits that go down. Sometimes they branch around, but each one of these is a little pit, gastric pit. And think of it as a gopher hole. But on the histology slide, it is very rare to get a good slide where you actually see a pit coming down and you see the whole entire hole. So the way they're sliced, it just looks like you see the start of it, and then it just looks like a jumble of cells. There might be a single gastric pit. This would be like you're looking down, and this would be the gopher hole. You know, so you're like, you have cells around it, but now there's going to be this tunnel. That's if you're looking down the ground at you. Then this next picture is the side view. So if you have the gopher hole or the gastric pit at the top, it has a longer distance that's going now into the mucosal surface. So it's within this distance that I want you to know this. I also really want you to notice our 4 layers in this histology slide. You have your mucosal layer. This will be the epithelial tissue, even though it's quite thick. This here is muscularis mucosa. So from this pink line up is mucosa layer. This is submucosa. You just see kind of connective tissue, kind of, again, no man's land. And then here, 3 distinct muscle layers, which obviously is unique to the stomach. What is this outermost layer called? Longitudinal. What's this darker pink middle one? Circular. And then what is this unique new one? Oblique. In the gastric pit, so we're going to expand this to, we show 2 gastric pits here. We would have the goblet cells that are going to be located in the upper third. Parietal cells, although this picture doesn't indicate, have a higher concentration in the middle third. The parietal cells secrete hydrochloric acid and intrinsic factor. And then we have chief cells. Chief cells are in a higher concentration in the lower third. Chief cells make pepsinogen. We won't worry about the gastric lipase. So what I want you to know from this is the stomach has 3 main cells that produce secretions. The upper third will be goblet cells that secrete mucus. The middle portion are going to be a bunch of parietal cells that secrete both hydrochloric acid and intrinsic factor. And then the bottom third is going to be a lot higher concentration of chief cells that secrete pepsinogen. So let's just focus on the chief cells and the parietal cells and what they secrete. The chief cells, which are the green ones, the lower third, they're going to send out pepsinogen. Parietal cells, which are in the middle third region, is going to secrete hydrochloric acid. They're going to do them separately because we don't want them to combine in the gastric pit. So when protein shows up in our stomach, all of a sudden that's a signal, hey, chief cells, send me some pepsinogen. Parietal cells, send out some hydrochloric acid. Together, they're going to form pepsin. Then parietal cells send out additional hydrochloric acid that's actually going to be used to drop the pH. That is going to make pepsin active. I like to think of pepsin as a chainsaw cutting up protein. So if a protein is, say, a log or a piece of wood, the pepsin is going to be a chainsaw that's going to cut up that wood into smaller, more manageable segments. So if you imagine pepsin as a chainsaw, think of step one, forms pepsin. You're making the chainsaw. Say it's sitting right here on a table, it's on idle. If it's just on, but it's idling, the chain might kind of rotate around real slowly. You can put your hand on it. You shouldn't, but you could. It's not going to cut you unless you do something, but it's, you know, it's relatively safe. It's sort of inactive, but potentially dangerous. Adding additional hydrochloric acid, the effect mainly dropping the pH. If you lower the pH, that pepsin chainsaw now becomes extremely active. It's like you're now pulling the throttle, and now it can actually do some cutting of these bonds. So here is my animation for this. This is a protein chain arriving in the stomach. Pepsinogen is produced by the chief cells. It comes out the gastric pits. Then we have hydrochloric acid produced by the parietal cells, also comes out the gastric pits, and together they will combine to become pepsin. That pepsin's really not going to do anything if we're just at a normal pH. Just kind of more neutral, nothing's really happening. Therefore, parietal cells secrete additional hydrochloric acid to actually make it acidic. Now our pH is going to drop down to 2 to 3. So now it actually can break bonds. And so this is where you'll have this activated pepsin molecule. Because of the low pH, it's activated. It's going to break apart the chains. And now we have a long protein chain into smaller segments. So our goblet cells at the top of our gastric pits will make a whole bunch of mucus here, and it's going to fill and plug up these gastric pits because we don't want pepsin to go back down into our gastric pits. We don't want activated pepsin to go into our gastric pits and actually digest ourselves. We don't want to break apart our own proteins. If you don't have enough goblet cells producing mucus in the stomach, you will get an ulcer. That's what an ulcer is, because you don't have the protection. So whether it's due to the H. pylori bacteria, whether it's due to stress, whatever is causing your goblet cells to not make mucus, you're going to get an ulcer. So this is a normal histology of the stomach. We're zooming in on the mucosal layer. We're going to have goblet cells at the top, parietal cells in the middle, and the chief cells at the bottom. Chief's going to make pepsinogen, parietal is going to make hydrochloric acid, and intrinsic factor, goblet cells are going to make mucus. This is an ulcer. Looks painful. Then this is another ulcer. Over here on the histology side, this side is normal, but here is the ulcer. It's actually eroded away, so you really have no mucosal layer over. The functional region is you don't have enough mucus plugging up your gastric pits, and that's really what's going on with ulcer. That is it for today.